Hello everyone. Today we are going to learn the step-by-step management of acute and recurrent urinary tract infections. This is very important for the exam. So let's go through this project together. We begin at the top. A woman presents with an acute UTI. We don't always need complex tests right away. The diagnosis can usually be made based on clinical symptoms, signs, and positive urine dipstick. But importantly, we should send and midstream urine sample for culture so we know which organism is responsible and what antibiotics is sensitive to. Once UTI is confirmed, we offer antibiotic treatment based on local guidelines or culture results. Now, here is where it gets interesting. If the patient has had more than 3 UTI within 12 months, we classify it as a recurrent UTI. So, what's the next step in recurrent UTI? We don't keep managing recurrent infections blindly. This is the point where we refer to secondary care for a proper evaluation. You have to maintain this step-by-step management. So, in secondary care, the goal is to rule out any underlying structural or functional issues. So, we perform cystoscopy, renal ultrasound, and Boyding studies. Cystoscopy to look inside the bladder, renal ultrasound to assess the kidneys and urinary tract, and Boyding studies to understand bladder function. If any abnormalities are found, they must be treated accordingly. For example, a bladder stone or obstruction would need intervention. But if all investigation come back normal, and this is quite common, the management now depends on the woman's menopausal status, which leads us to pathways. One is premenopausal pathway, another is postmenopausal pathway. First, premenopausal pathway. For younger women without estrogen deficiency, we consider GAG replacement, glycosaminoglycan replacement therapy. This helps to rebuild the protective bladder lining, which might be compromised. This regimen includes 4 weekly installation and 2 monthly installations. These patients are followed up for 12 months, and if they remain stable, we can discharge them to primary care. Now, the postmenopausal pathway. This is very commonly asked area in exams, so pay special attention here. Why are postmenopausal women prone to UTIs? You have to know this first. Because with declining estrogen, there is urogenital atrophy. This causes thinning of vaginal and bladder lining. And disruption of normal flora. So why are postmenopausal women prone to UTI? Because of declining estrogen, there is urogenital atrophy, which causes thinning of vaginal and bladder lining, and all causes disruption of the normal flora. So all of which predispose to infection. So if the woman is postmenopausal and investigations are normal, we offer low dose vaginal estrogen. We then follow up for 12 months to monitor symptom control. Now, if she still get another acute UTI, during this period, we don't stop everything. We continue vaginal estrogen and offer GAG therapy as an additional measure. If she stabilizes, we can confidently discharge her to primary care for continued maintenance. So it's all about balancing investigation, targeted therapy, and follow up. And very importantly, remembering that postmenopausal treatment is a hotspot for exam questions, especially regarding when to offer low dose vaginal estrogen.